Hi, welcome everyone. Myself Anusha, Assistant Professor, School of Physiotherapy, Sri Balaji Vidyapeeth, Deemed to be University, Chennai campus. We are going to see about coordination and balance exercises today, which is most important for execution of an activity for a human being. So, the objective of today's class is at the end of the session we should come to know the definition of coordination and balance, prerequisites of coordination and balance, principles of coordination exercises description with the position of the patient, position of the therapist, progression, repetition and the precautions to be taken, and the identifying the graduation of balance training and the balance exercises. So, what is coordination? Coordination is nothing but ability to select the right muscle at a right time with a proper intensity to achieve a proper action. The ability to select right muscle at a right time means when we are supposed to take something from a pocket or from the other side of the table or from somewhere else like a bookshelf or something. So first we have to lift our hand and extend our elbow. Then we have to grasp the thing like a gross motor activity. For this our muscles has to work. So before all this our higher centers has to work, coordinate the thing with the feedback control system. Then it will send signals to the muscles. Then our muscle works. The ability to smoothly execute the accurate motor response depends on the deep sensation, vision, vestibular system, cerebellum, motor system, flexibility and range of motion. Deep sensations are nothing but which are present in the joints, muscles and tendons. They are kinesthetic awareness, proprioceptors and the other joint receptors. Next is the vision, which is responsible for accurate gaze because only with the proper vision the person could perceive where the object is, how to perform the movement. Then the vestibular system and the cerebellum. Vestibular system, which is responsible for maintaining the position of a human being in the space. Cerebellum. Cerebellum is the higher center, which is the processing unit of balance and coordination. Next comes the motor system. Motor system is nothing but our thalamus and the cerebral cortex, where the information gets processes and these information are sent to the cerebellum for the smooth execution, then to the spinal cord through the efferent pathways, then to the muscles. Then the flexibility and range of motion. If all these other systems are working perfectly, though the flexibility is also okay, then there is a muscle weakness. The subject couldn't perform the coordinated movement. Next is the dexterity, agility and the visuomotor. The types of coordination are dexterity, agility, visual motor coordination. Dexterity is nothing but the fine motor function using the fingers. The person doing fine motor functions using your fingers and the hands. Agility is to perform an activity smoothly, initiate smoothly, stop when required and modify the movement according to the direction, maintaining the partial control. That is, when a subject is about to take an object from one side, if the object moves to the other side, it has to move in a direction where the object is moving without losing the partial control. For maintaining the partial control along with the cerebellum, vestibular system is very important. If there are any vestibular disturbances, the partial balance might be lost. Then is the visuomotor coordination. Visuomotor coordination, again the vision is very most important. Only with the help of our eyes we can able to perceive where the object is, how the object is moving, and it sends the impulses from the vision, that is through the optic pathway to the brain and processes the things, and it sends back to the spinal cord, from the spinal cord to the muscles to accomplish the goal. Next comes the mechanism of neuromuscular coordination. As we have discussed earlier, the motor pathway. The action of each muscle is determined by the afferent muscles which reach it by the motor pathways. That is, the muscle suspects how the action has to be done. This suspicion is nothing but usually while performing a movement, agonist works, antagonist inhibits, and the synergist helps in performing the movement. Agonist is nothing but to take an object from the table, our shoulder has to be in a flexed position with an elbow extension. For the shoulder flexion, the agonist muscles are shoulder flexors and the antagonist and synergist muscles are shoulder abductors and the shoulder extensors. Then for elbow extensor, the agonist muscle is a triceps and the antagonist muscle is a biceps which works. As we know, agonist is very important for performing a movement. Apart from the agonist, the antagonist has to be in a predetermined way so that the movement can be executed in a smooth manner. Then comes the cerebral cortex. After these impulses, the inhibition of certain muscle groups and the activation of certain muscle groups, which is after this, the impulses are being sent through the afferent pathways to the cerebral cortex. In the cerebral cortex, it sends the impulses to the thalamus and to the basal ganglia and it processes the information there. Then it sends the impulses to the cerebellum for the refinery movement through the feedback systems. The feedback system is nothing but the information which has been already stored in the brain, and it processes and it perceives the information and it remembers the previous activities, then it performs the needed activity. Then the kinesthetic awareness. For this, the kinesthetic awareness, the proprioceptors situated in the muscles, tendons and others has to be in a proper manner, that is in a proper functioning way. For example, in a case of fracture or in a case of repeated injury, that is in a case of OE or ankle stability, this kinesthetic sensation will be lost. The proprioceptors activity will be decreased comparatively to the other normal joints. So the activity of coordinated movements and maintaining balance in the space will be affected. Incoordination. The incoordination is nothing but interference with the function of any of the factors which contribute to the production of a coordinated movement will result in a jerky, arrhythmic or inaccurate movement which is said to be incoordinated. The four main types of incoordination is based on the location of lesion causing it. Incoordination associated with the weakness or flaccidity of a particular group of muscles. These type of incoordination we can see in the lower motor neuron lesions like Guillain-Barré syndrome, tabes dorsalis, where our thalamus, cortex and the cerebellum, vestibular function, vision, everything will be in a proper manner, everything will be performing its own activity in a coordinated manner, but still those sending the impulses from the higher centers to the spinal cord. In the spinal cord, the processing centers, that is the anterior horn cells of the spinal cord, fails to send the impulses from there to the muscles. So the efferent pathway is getting affected from the spinal cord to the muscles. So the person might not perform the activity in a coordinated manner. The lesion of filament prevents the appropriate impulses from reaching the muscles, or the condition of the muscles modify their normal action to these impulses. In tabes dorsalis, in other conditions, syringomyelia, what happens? The patient can stand, but he cannot stand in a balanced position. The patient can take something from a table or can have his own food, but not in a normal rhythmic manner. He might spill while taking the food from the plate or while taking it to the mouth. Next comes the spasticity of the muscles. The spasticity, which is common in the upper motor neuron lesion, which is nothing but the Parkinson's, stroke, etc. What happens during Parkinson's and the Stroke. In stroke, the pyramidal tracts get affected. Pyramidal tract is nothing but which sends the impulses, that is the processed information from the brain to the spinal cord, from the spinal cord to the muscles, which is getting affected. So the impulses which has been processed in the higher centers fails to reach the spinal cord. So the patient couldn't do any movement. The patient will be in a fixed manner in case of a stroke. That is, in case of a latent stroke, the patient, if the patient goes for the 2 spasticity, according to the grades of modified Ashworth scale, the patient fails to do even a smaller movement. But in case of a Parkinson's, which affects the basal ganglia, which is also an important center for coordinated activities, the globus pallidus and the substantia nigra gets affected. So the impulses from there, the processed impulses from there fails to reach the spinal cord. The impulses fade away before reaching the spinal cord. So the patient might perform a activity in an arrhythmic manner. That we call it as an intentional tremor. When a patient tends to do some activity, the patient hands goes for a shivering. So we call it as an intentional tremor, that while doing an activity, the patient gets a shivering or a trembling in the hands. Next comes the cerebellar ataxia. The cerebellar ataxia, we have a very many centers, processing centers for the balance in cerebellum. If those centers are affected, either in a neocerebellum or the other parts of the cerebellum, it affects the truncal part of the body and the other proximal joints. Especially in cerebellar ataxia, we can see a titubation of our head and the truncal ataxia comparatively to the stroke patients. So while performing the activity, the patient couldn't perform an activity. The patient might have a fear of fall or a fear of dropping some things. So next comes the loss of kinesthetic awareness. The loss of kinesthetic awareness, where the cerebellum will be functioning in a normal coordinated manner, the higher centers would be in a normal coordinated manner and performing the activities. The spinal cord and the impulses from the spinal cord, that is the motor impulses from the spinal cord to the joints, will be in a normal coordinated manner. But the joints which has to process the information got from the higher centers and the spinal cord fails to process the information because of a loss of the kinesthetic awareness, that is a joint position sense. In case of an arthritis, where we have a joint receptor surrounding the joint capsules, goes for the degradation, then these joint receptors are reduced and goes for the diminished activity. We would have seen in case of a chronic ankle instability, where there would be a proprioceptive loss, the patient goes for a frequent falls. Even when a patient stands in an unstable surfaces, the patient might tend to fall, though they are in a lower age or the older adults. Next we are going to we'll be seeing about the re-education, which is very important part for coordination activity. The re-education is nothing but re-educating the activity which has been lost. The thing is, it is mainly depending on the neuroplasticity. It is already stated that even in a case of a higher motor, upper motor neuron lesion, it is said that the complete neural activity will not be stopped. In a very rare scenario, the complete neural activity would be stopped. Always will be having a connections. That is, we have a regeneration of neurons. So with those connections, with those regenerations, we can able to restore the functioning of the systems. So the principles of re-education are nothing but concentration, precision and repetition. Concentration with the visual feedbacks and with the verbal cues, we have to keep the patient concentrated while doing a movement, so that whatever the patient is performing a movement, it gets registered in his brain. If the patient does the movement for so many times, it gets thoroughly registered through the neuroplasticity of the brain. Then comes the precision activity. The precision activity is nothing but the accurately performing an activity in a precise manner. With the verbal cues, we have to initiate and make the patient to do in a precise coordinated manner as per our orders. Thank you.